Welcome to the HIMSS Interoperability Showcase and our demonstration around childbirthing. This use case is made possible by the use of the IHE and HL7 interoperability standards, including the newly released Electronic Initial Case Reporting Standard, the EICR. I'm Elizabeth McKnight. I'm here today with my colleague, Jeremy Carr. We are from the Alliance of Chicago, a health center controlled network based in Chicago, Illinois. We support 35 community health centers in 15 states. We use this GE Centricity electronic health record and a Quivera interface engine to integrate with hospitals, health departments, and other entities to facilitate continuity of care. Our role today in this use case is to be the primary care provider at a clinic in Utah, caring for Karen King, a 33-year-old female seeking prenatal care for her pregnancy. Karen presents to the Utah clinic in her first trimester. Jeremy is sharing information on the monitor today around the prenatal visit summary. During the initial visit, we completed a prenatal lab panel, including a screening for all sexually transmitted infections. We are now showing the lab results indicating that Karen has been diagnosed as positive for gonorrhea. The positive gonorrhea diagnosis in the EHR triggers automatically an HL7 message through the Quivera interface engine, which extracts the electronic initial case report from GE. This is then transmitted to the Utah Department of Health in accordance with local policy around reporting specific communicable diseases. Amanda is here today from the Utah Department of Health to explain more.
Thanks. Yep, Amanda Whipple, Utah Department of Health. We received the EICR, which is the new standard from HL7. It contains all the patient information in the electronic health record. The EICR is automatically triggered to us because gonorrhea is a reportable condition. But before we can receive the EICR message into our surveillance system, it's processed through our electronic message staging area, which we call EMSA. EMSA is our rules engine, and what happens in EMSA is person matching, deduplication of cases, and condition determination of diseases. This system is really important for us because we receive a high volume of reports every week, about 17,000. But because of the standard format, we can automatically process about 90% of the reports we receive. So 90% requires no human intervention. And receiving the reports electronically improves our timeliness, accuracy, and completeness. Once the message comes through, it's imported into our disease surveillance and case management system. Reports in the system are initiated through electronic case reporting and electronic laboratory reporting. I'm just going to go ahead and search for the patient. And there's the record that came over to us. Once the system opens, you'll see that all of the fields were automatically filled in with the data that came over through the EICR. At this point, the Department of Health would share it with our local health jurisdictions to conduct the gonorrhea investigation. Once the investigators get all the information they need, the case is closed out and any pertinent information is sent on to relevant agencies.
Thank you, Amanda. Karen, the patient, continues to be treated at the Utah Clinic for gonorrhea with the administration of Rocephin and its prescribed oral antibiotics. Karen continues to be seen during the course of her pregnancy at the Utah Clinic. During her third trimester, the Utah Clinic receives an automated request from a hospital in Georgia to request a CCDA that includes an antepartum summary to from Epic. She has presented at the hospital with complications, and Danielle from Epic will tell us more.
Hi there. So Karen shows up to our hospital in Georgia. We've never met Karen before, so we had to request her records from her Utah clinic. And so we pull up her chart. Here we're going to look at the CDA document we got from Utah and reconcile that data into the chart. So we noticed that she was diagnosed with gonorrhea and that she was started on a medication for azithromycin. We asked if she finished that prescription as prescribed, but she said that she developed hives for that medication and stopped taking it a while back. So we're going to enter that into the chart really quick. She had hives. At this time, since she is 8 months pregnant, we're not sure how to proceed with treating her gonorrhea. And so we launched the Fire Apervita app. This is not an Epic app. It lives outside of the provider's workspace, but because of Smart on Fire, it is now embedded directly in their workflow, so they can access that easily to see CDC guidelines for care. I'm going to hand it to Andy to tell more.
Hi, I'm Andy Schriever from Appervita. Appervita is a platform for clinical informatics and shared clinical insights. In this use case, our objective is to analyze patient data and deliver a customized plan of care for this patient. To do that, we reach into the Epic database using the emerging FHIR standard for data interchange. We retrieve information about the patient's allergies, problems, and demographics, and apply those to the CDC guidelines. As you can see in the screen, we make decisions based upon the data that we've retrieved. Those are illustrated in blue, and so we determine the patient is in fact positive for gonorrhea, the patient is in fact allergic to azithromycin, and critically, the patient is pregnant. What that means is that there is no standard dosing regimen for this patient's circumstances. Instead, we need to direct the clinician to immediately order an infectious disease consult to determine the best path of care for the patient. That is easily done manually, as Danielle will now do. In a tighter integration using additional Epic APIs, we might actually have submitted that order directly within the Epic system. In any event, the most important thing illustrated here, I think, is that not only have we interacted using data formatting standards like FHIR, but we've also achieved data level interoperation. We've determined what the data means in terms of allergies, in terms of conditions, and crafted a customized care of plan.
Great. So now that we've cared for Karen and her gonorrhea, we're going to jump over to her baby who has just been admitted to the NICU.
Hi, my name's Leanne. I am a registered nurse. I work for HIMSS Medical, the manufacturer of the MedFusion 4000 pump. We have interoperability capabilities with Epic. I'm going to switch gears a little bit and show the benefits of smart pump programming and auto documentation as it benefits the clinician, specifically today in the NICU. So Patrick was delivered and immediately started showing some signs of distress, respiratory distress, and lowering blood pressure. He was transferred to the NICU. At that time, he had baseline labs drawn, which were very early indicative of sepsis. So he had multiple orders placed for several different medications. The nurse, one of the things that interoperability can do is improve workflows for nurses. So we're just going to demonstrate right now how that workflow works. Typically, the nurse would scan the patient in order to open up that patient's chart. The nurse would then scan the medication that they are getting ready to deliver. Once that is scanned, then the nurse needs to scan the pump that they want to connect to that medication. The nurse will do their order verification here, make sure that it looks correct, and make sure that the pump that's on the screen matches the pump that they're getting ready to infuse. And then they can actually send the actual order to the pump. So the programming button on the pump will then light up when it's ready to receive the order. The nurse does pause at this moment. They still want to verify. They're still that gatekeeper of medication administration, so they want to match the order on the pump to the order they're getting ready to deliver. Once they confirm that, then all they have to do is hit start. It has the ability of preventing keystroke errors, concentration errors, and then it also, with the auto documentation on the MAR, has those specific start and stop times, so that benefits reimbursement. The auto documentation of the infusion also benefits the nurse, and it prevents them from being that data entry clerk. They then have more time to spend at the bedside. They do still have to verify all infusions and sign off on them before they'll become a permanent part of the medical record.
Great. So now that we have treated Patrick's sepsis, we are going to head over to his facility worksheet and mother's worksheet, which the birth clerk are going to submit to the Georgia Department of Health. Here we load that and send off a BFDR message, which is the birth and fetal death reporting document, to Genesis. Genesis creates this form and it pre-populates it with the information we sent in that document. So there is no double documentation, it's already filled in for us. So you'll notice the gonorrhea we've already charted, as well as that NICU admission. There will be some state-specific questions that might come up, such as, was a metabolic screening performed? At which time we might not have documented that yet, and we would fill that out now. From there, we'll go ahead and submit that to Genesis, and I'll hand it off to Chad.
Okay, thank you, Danielle. My name is Chad from Genesis. This is my colleague, Joe. At this point, we've watched as the information has flown from the primary care provider through the birthing center and is now being sent on to the state, so we can now provide the vital event recording, in this case, the birth of Patrick King. So we've seen the information come from the source where it is the most valuable and the most the closest to the original event. So we are looking for the accuracy and the non-rekeying of data as it comes through. So as we're looking at the record here, we can see it was Patrick King's. We have the gonorrhea of his mother Karen that is followed through. The charts are now ready for the state to record. The NICU admission for Patrick has come through as well. And as Danielle had shown, the metabolic screening was performed for the infant as Georgia has asked for. As far as the mother's worksheet, as Danielle had mentioned, it's pulling in some demographic information that the state and federal government are using to compile statistics in different reporting levels. So as we can see here, we have a bachelor's degree, and the mother's ethnicity and race are both pulled through on the form, coming directly from the mother instead of from the mother through the birth clerk. So we're catching it at the closest spot again. So as we save the record here, two things are happening. The first is we are creating a CDA document that is going to be transferred to the CDC and NCHS through the SAMS upload folder. So as we put that through, it'll send the message directly to them, so they will then have the message for statistical reporting and all the information they need to glean from it. The second thing that happened is, since the baby Patrick was born in the state of Georgia, it is considered a Georgia birth, but he is a resident of the state of Ohio. So we've created an HL7 2.5.1 message that will send in real time to, I said Ohio, but I meant Utah. So we will send it to Utah, and that's part of the interjurisdictional exchange, so they can get the information as it's happening instead of in weekly reports, as has happened in the past. So I will hand this over to Amanda so she can show you what Utah looks like.
So Utah Department of Health Vital Records would receive a report of live birth. Even though the birth certificates are issued by occurrence, both the mother and the baby are residents of Utah. So here is the report that we received, and that's the real-time message of the birth. Mainly we received this for statistical reporting, and now Elena will explain more from CDC.
Thanks, Amanda. I'm Elena with the National Center for Health Statistics, one of the centers within the Centers for Disease Control and Prevention. And our mission at our center is to provide statistical information to guide actions and policies to improve the health of the American people. So within our center, we have our Division of Vital Statistics, where we collect and disseminate all of the nation's official vital statistics, including births, deaths, and fetal deaths. And these data are provided to us through contracts between NCHS and the states and jurisdictional vital records offices that are legally responsible for registering vital events. So our division director has a hypothesis that by using the EHR data, we may be able to improve vital events reporting, and to move this forward, we support vital record standards, the development of vital record standards, and to enable interoperability between the EHR and the state vital records systems and the U.S. vital record systems, and basically any other public information system that might be interested in birth, fetal death, or death. So in the case that Chad just described, Genesis sends NCHS the birth report, the HL7 birth report, through our SAMS network, our Secure Information Management Network. Comes to us it comes into a file share. I can open that file, and I can show you that this is indeed baby Patrick. And then I just want to end by showing you an example of some birth statistics. For example, birth rate, fertility rate. When you see these types of statistics, you know that we generated these by collecting this type of data.
Thank you. So Patrick recovers, discharged from the neonatal intensive care unit, and returns with his mother to Utah. The Utah clinic then re-engages with the patient to continue her postpartum care. On her initial postpartum visit to the Utah clinic, we trigger an automated message to Georgia's hospital, and the Epic system returns back to Utah a CCD, which I believe we're displaying here on the monitor. So all the information now is available in Utah from the hospital in Georgia. So by use of the IHE, HL7 interoperability standards, the Alliance of Chicago, APRAVITA, Epic, Genesis, Smith Medical, the Center for Disease Control, and the Utah Health Department have been able to continue this patient's care with its seamless continuity. Thank you very much.